back. So I want to welcome all our subscribers and viewers on behalf of East Kolkata Doctors Group. We are celebrating the Thyroid Awareness Month, and we have with us two eminent endocrinologists from India, Professor Satinath Mukhopadhyay and Dr. A.G. Unnikrishnan from Pune. We'll take this opportunity to just look through certain important issues related to thyroid. So without wasting much time, can I start off with Professor Mukhopadhyay with a very simple issue? Nowadays, patient comes with bunch of tests. From where I come from, it's an office area, and the office makes it mandatory to do this bunch of tests, 30, 40 tests. And patient comes and says, Doc, everything is fine, but in bold, they have written that the TSH is 6.5. But all my other parameters, thyroid, T3, T4 is normal. Should I be put on a thyroid replacement therapy? So how do you normally deal with such patients?
Well, it's good in a sense that such bunch of tests are done, and you get an opportunity to see such asymptomatic patients with elevated TSH. So I mean, they keep feeding you those package tests, right? But then jokes apart, so this single elevated TSH is something that we should not jump into treating. We are not about to treat TSH levels. We are about to treat the patient. So a couple of things. This patient is a male, right? The
Right.
index patient, and so TSH levels in the extreme of ages, say in the elderly above 60, 65, and then in the adolescents, uh, we should be very careful before we jump on to treat that. Unless the patient on examination has symptoms or has a goiter, there's no harm in waiting for 6 months and get a repeat TSH. So if that one is again high and higher than the previous one, then again you can reassure the patient and do a third TSH 6 months down the road. So rising TSH levels in a patient who doesn't have goiter or symptoms suggestive of thyroid hormone deficiency is an indication for treatment. Otherwise, the patient has high TSH and has a goiter, fine. So maybe you need to start treatment. If the in a situation where you are not able to make up your mind, and sometimes the patients also tell you, no, doctor, this is something I'm really concerned about. So do a thyroid peroxidase antibody. If the antibody level is clearly high, then it makes sense to start treating the patient, because most patients with positive antibody levels, they eventually progress to a state of overt hypothyroidism. Sorry. Having said that, uh, in routine clinical practice nowadays, what you see increasingly is that obesity. Any obese individual can have a slightly elevated TSH, and this is because of the hormone leptin, which is released from the adipose tissue, stimulates hypothalamic TRH. That in turn stimulates the TSH, so you have slightly high TSH level. This clearly has no significance except to remind the patient that you need to lose your body weight. And on rare occasions, of course, those patients are unlikely to be asymptomatic, say primary adenocortical insufficiency. So at a subclinical level also, they may present with slightly elevated TSH. So clearly the endocrinologist needs to look into that. But at a general practice level, if the patient is totally asymptomatic, physical examination is normal, no goiter, as I said before, wait for 6 months. Reassure the patient, wait for 6 months, repeat that TSH, and then take a call. Thank you.
Thank you, Professor Mukhopadhyay. I'll just stick on with this and change the male to a female. And I've read a few of your publications, Dr. Unnikrishnan, on this particular area. And that's why I think it's apt I ask you two things. One, it's the same. This is a lady planning to conceive. Again, free T4 TSH is normal, but it's a T4 T3 is normal, but TSH is 6.5. Sometimes even if the TSH is normal, we get referrals from infertility clinics that the TPO is very high, get something done about it. How do you approach such a patient who comes to you willing to conceive? I think we have lost his video. Would you like to take that in his answers? Yeah.
You're asking me?
Yes, yes.
Oh, okay. Yeah. So, yeah, it's a different ball game altogether when you encounter a female with an elevated TSH. And this patient is contemplating pregnancy, as you said, so referred from an infertility clinic. Well, so even a borderline elevation of TSH needs to be treated because pregnancy as a situation puts a stress on your hypothalamic pituitary thyroid axis. And even if your T4 and T3 are normal, a slightly elevated TSH tells you that your pituitary is hypothyroid, right? So when it's put under the stress of pregnancy, the hypothyroid state is likely to progress, which means your thyroid actually has a poor reserve. That's why the TSH is slightly elevated. So during the course of pregnancy, this thyroid reserve is again going to be put under stress, and the patient is likely to go into overt hypothyroidism, and that's why such minimally elevated TSH levels are routinely treated in pregnancy to maintain a target of TSH
Sorry.
below 2.5. Uni, you can take over.
So sorry about that.
Yeah.
Uh, I think my camera got a little hypothyroid. so I think TSH 6.5 lady planning pregnancy is one of the indications where we would like to treat. Now, if you look at the American Thyroid Association guidelines, they say that if the TSH is above 4, you wait till the TSH is below 4 to start treatment. And once the TSH is below 4 to start plan pregnancy. And once the TSH is below 4, the lady can go ahead and plan pregnancy. And once a lady is pregnant, then we may have to keep the TSH below 2.5 in the first trimester, below 3 in the second trimester, and below 3 in the third trimester. Now, it's very important to note that if it's 6.5, the dose can range from 50 to 75. The American Thyroid Association says 50 to 75, so maybe 25 may not be enough. A 50 dose may be required. Now, the other question that Dr. Samit asked, that we usually get referrals from infertility specialists, that if the TSH is normal and there is a history of infertility, should we treat or not? So this was explored in a randomized controlled trial of TPO positive women who were pregnant and who were given thyroxine. And they found that giving thyroxine to TPO positive pregnant women with a normal TSH improved the outcome in terms of pregnancy outcomes. But when they went back and analyzed, they found that majority of these patients who benefited had a TSH between 2.5 to 4. In
Yes.
other words, if the TPO is positive, if the woman has infertility or a bad obstetric history, and if you want to selectively treat those women, you may treat those women if the TSH is between 2.5 to 4. Now, if the TPO is positive, the TSH is below 2.5, I don't think we should start treatment. There is no evidence, and there is no evidence of benefit, and there is probably unnecessary treatment in that situation. So, to cut a long story short, TSH 6.5 planning pregnancy treat, TSH between 2.5 to 4 with infertility with TPO positive antibodies, treat. TSH below 2.5, don't treat. So that leaves a gray area. TSH between 2.5 to 4 with TPO negativity and a bad obstetric history. Probably one would discuss the risks and benefit and still offer treatment to those patients if the pregnancy history is really poor.
Yes.
So 2.5 is a very important cutoff figure that you're giving us. So we've discussed on the subclinical and hyperthyroid. Now, before jumping to the other extreme of hyper, I like to spend a little bit time of something in between. As I was discussing before the program started, I saw one of the patients. Very frequently, we see after some post-viral infection, a slightly tender or sometimes even acutely tender thyroid hormones. The patient comes and they have those symptoms, like they lose weight. They have palpitations. It looks absolutely like a hyperthyroid, but they don't usually have the eye symptoms. They have more or less the rest of it, mimicking Graves' disease. And we see that such patients have slightly detectable, I mean, low TSH, but actually it's detectable. And T4 or free T4 or T3 is elevated. Again, should we just jump and start a carbimazole in such patients? Should we put them on, say, a beta blocker, wait, and put them on NSAIDs or steroid? How do you approach such a patient, Dr. Unnikrishnan?
Oh, so thank you for that question. As I understand it, the patient has got throat pain, fever, and then there is a TSH which is suppressed. And then the question is, and the T4, T3 may be slightly elevated. You're thinking of whether to treat or not. Now, in this situation, the most common diagnosis is a subacute viral thyroiditis, which may be painful. Now, in this situation, once you've made the clinical diagnosis, there's no need for other tests. You can just follow up the patient. Having said that, sometimes you want to confirm the diagnosis, and sometimes the patient also says, doctor, I want to be very sure what's happening. In that case, you are left with two options. You are left with doing a TSH receptor antibody, or you are left with doing a thyroid uptake study. Both may be done, but a thyroid uptake study will likely to give you a very clear picture, but it involves some little bit of radiation. You might like to make sure the lady is in breastfeeding or planning pregnancy. So once you do that, you will get a differential diagnosis. It could be thyroiditis, it could be Graves' disease or some other thyroid disease. Probably it will pick up thyroiditis. Now, if there's thyroiditis uh, and it's painful, the best thing is to manage with NSAIDs and wait it out. Because even if you give carbimazole, carbimazole works by decreasing the synthesis of thyroid hormones. This is a damage of thyroid gland and leak of thyroid hormones. So in this situation, you would be better off waiting and repeating the thyroid function, say after 6 weeks. Now, supposing with NSAIDs, the pain isn't getting better, it's exquisitely tender, you find that the pain is radiating up to the ear and the patient is in distress, then you can give a small dose of prednisolone. I usually prefer zero point 0.5 to 1 mg per kg body weight. That is about 40 mg on an average, 30 to 40 mg. And then taper it over the next 6 weeks, and you'll see a pretty, one of the very satisfying situations where the patient suddenly says, feels better and everything is okay. So that's one situation. But as I said, steroids are usually the exception rather than the rule. So this would be my approach. So what I like to tell my patients is, you may have a make problem or a leak problem. A make problem is like Graves' disease or thyroid toxic adenoma or multinodular goiter, which is your gland is actively making hormone. A leak problem is thyroiditis. To differentiate between the two, we can go for a thyroid uptake study or a TSH receptor antibody. And usually I prefer a thyroid uptake study. And that sort of, then after the results come, I tell them, this is a leak problem. Medicines will not help. You will need to wait it out and things will settle.
So to screen initially, do you do a TRAB and then go for a radioiodine uptake? That's the sequence usually.
So usually I do a radioiodine uptake because I don't know, because that was how we've been practicing for years. But I agree with you that if a TSH receptor antibody test is readily available and you do it, if it is positive, it's very highly specific for Graves. I mean, you don't get it in any other disease. But if it is negative, it may not completely rule out Graves or thyroiditis. You are left with a little bit of nagging doubt, which you can always follow up and see. So that's why I prefer to get the thyroid uptake study done to clear it. Now, there is one situation where thyroid uptake study won't help. If this subacute viral thyroiditis has been somewhere in the little remote past, say today the patient has come to you and all this viral fever and thyroiditis and cough and cold has happened in October, and here if you do an uptake, you might get a normal uptake. So then the question is it a resolving thyroiditis or an evolving Graves? So if all this thyroid viral fever sort of thing has happened in the remote past, then I think you have to do a TSH receptor antibody. That will pick up the Graves' disease, and if not, you can just wait it out.
Thank you. Thank you, Dr. Nikrish. Professor Mukhopadhyay, now I just want to go into the frank hyperthyroid, right? So now it is undetectable, TSH, patient doesn't have any viral prodrome. Again, do I straight away start the patient on therapy with carbimazole, or is there a role of investigating further to find out whether it's a single toxic nodular goiter or it's multiple nodules were involved, or should we just straight away start treatment with carbimazole? I think you're mute.
Sorry. So
Yeah.
let me repeat that again. The diagnosis of Graves' disease is essentially clinical. So if we have a patient with typical symptoms, we have a diffuse goiter, and the thyroid brew is quite specific for Graves' hyperthyroidism, and you have the typical biochemistry and a T3 T4 ratio exceeding 20 with eye signs. Nothing else is required.
Yes, so I was talking about
Nowadays,
without eye signs. So, and
yeah, so
yeah,
without eye signs, and nowadays, this TSH receptor antibody levels, since they are more readily available and affordable, so they are being increasingly used. One is, as Unni said, it's highly specific for Graves' disease. The second thing is, if you do a baseline TRAB, then you follow it up after the patient has been put on antithyroid drugs, and a declining TRAB level with a declining goiter would identify those patients who are likely to go into remission with medical treatment. So that's another advantage of doing a TRAB at the baseline and then following it up. In areas where TRAB is not readily available or not affordable, well, again, you have to go clinically. See, clinically, it's usually not difficult to differentiate between Graves' disease and subacute thyroiditis. And the T3 T4 ratio also helps. On the other hand, elevated ESR CRP, they are pointed towards subacute thyroiditis. So with a mix of investigations and clinical parameters, I think you can start the patient on antithyroid medications.
and Professor Mukhopadhyay, now we see a few of the, or rather only one company coming and saying we also have methimazole. So a very common question comes that if we are about to start, do we start with carbimazole, and is there a difference in choosing between the two molecules?
Methimazole works as well as carbimazole. Only thing is that carbimazole is a prodrug which is converted to methimazole in the liver. So unless the patient has hepatic dysfunction, significant hepatic dysfunction, it's a cafeteria choice
Correct.
between methimazole and carbimazole.
Correct. So I can drag that same question now to you, Dr. Unnikrishnan. Is now this lady is diagnosed with a Graves' disease, doing good on a carbimazole. Now, what do you do? Do you continue that? Do you convert to propylthiouracil, or do you stop it? How do you approach the patient?
The lady is planning pregnancy.
No, already pregnant, diagnosed with
Already.
Graves' disease. Yeah.
So once the patient is pregnant, then if the patient is on carbimazole, as per the recommendations, you'll have to give PTU in the first 3 months and switch on to carbimazole in the last second and third trimester. So that's a guideline. Now there are 2 or 3 problems with this guideline. The first problem is now a patient is very well controlled, stable on carbimazole. The moment you switch to PTU, you might find some instability, and usually in clinical practice, we find instability. The second issue is that sometimes the patient is going to come to you not at the diagnosis of pregnancy. Patient may arrive to your clinic at the 8th week or 10th week, which is very close to the end of the first trimester. Because of these reasons, I would still, in the first scenario, if the patient is just pregnant and just missed the periods, I'd probably shift to PTU, tell them to accept a certain degree of instability, explain to them about the the aplasia cutis with carbimazole in the first trimester, and the hepatic problem with PTU in the second. Shift to PTU. Maybe I'd give about, if 10 mg of carbimazole is equal to, if we take you take it into 100 or 10 equal to 100 sort of calculation, I would still like to give a little bit lower dose of PTU and then give it 3 times a day and continue. Now, supposing the patient has come, and this happened to be recently, patient came in the 10th week, and then carbimazole, patient is already on carbimazole, and there's just 2 weeks to go, and then we have to anyway shift to carbimazole. In that case, I'll just explain and continue carbimazole, because aplastic UTS is a very rare complication, and I haven't, not that me or you or anybody not having seen is not evidence of that it doesn't occur. It does occur, but the chances are so remote that it is worthwhile to not shift to PTU for the last 2 weeks and accept the risk of aplastic cutis for a short period, rather than allow the control to again drift, that you shift to PTU and again shift to carbimazole, and that leads to some instability. So I think given these situations, patient comes early, I'll shift to PTU. Patients come towards the end of the first trimester, I'll probably continue carbimazole.
And before I switch over to the last part, which is the thyroid nodule and cancer, would you like to briefly tell us about the huge thing about diet and thyroid? Even a hypothyroid patient comes and says, "Can I have? I've been asked not to take cabbage and many other food items." So, do you want to comment on that?
So, I mean, as you know, before I moved to Pune, I used to work at the Amrita Institute, where I had the privilege of working with Professor R.V. Jayakumar. And every question he had a fantastic answer to the question which patient asks. So he says two things. First, he says that if the thyroid gland is already not working, to frankly hypothyroid patients whose initial TSH had been say 200 and they're on 150 thyroxine and TSH is 2 and they're asking, should I avoid cabbage? He used to say, when the thyroid gland is already damaged, how can you damage it more? Your gland is already destroyed. How can you destroy it more with anything? Both Bengal and Kerala are states where there are a lot of strikes are very common, at least in Kerala. So you used to say, if the factory is already closed, why do a strike on that factory? That factory is anyway closed. So that is what we used to tell the patient. There's no point. Secondly, so that these sort of examples, the patient understands very well. Okay, now it's already damaged, no problem. The second thing he used to tell the patient, which I remember very well, that these members of the brassicaceae family, the cruciferae family, cabbage, broccoli, kale, and all those things, they contain only very trace amounts of thyroid damaging chemicals. So you'll have to eat a huge amount to actually damage the thyroid. Having said that, it's better not to eat this raw in huge amounts. But if it is cooked, it's okay. The final thing which I always tell my patient is that there's no specific thyroid diet. There's no thyroid diet that you can follow. Most of the diet is good enough. Yes, some foods like soya can interfere with the absorption of thyroxine. And many patients nowadays on keto diet, they take soy milk instead of the real milk. And the real milk also can interfere with absorption because it contains calcium. So as long as you're taking the food tablet 45 minutes before meals, it doesn't matter. There's also some very, very, I'd say, not very clear, but some data that caffeine or coffee can impair the thyroxine absorption. But so you can take it later. The third thing is iron. Iron deficiency, as you know, iron is a component of the thyroid peroxidase enzyme, T2 enzyme. So it's very important. Iron deficiency can trigger autoimmune disease and some hypothyroidism. But again, iron itself can impair the absorption of thyroxine. So if the patient has to take iron, they can take it later after the meal. Or if the hematologist or the gynecologist wants to give iron in the morning, they can take the thyroxine 2 hours after dinner. There's some evidence to say that. The final thing is about iodine. So iodine restriction maybe can work a little bit in Graves' disease, where if patient is on an iodine-rich diet, the dose of carbimazole can go up. But other than that, we cannot at present recommend for or against iodine supplementation or eating any iodine-specific foods. And finally, there is selenium, which it can have a marginal effect on thyroid orbitopathy. There's some evidence that it can reduce autoimmune thyroid disease in pregnancy, but again, no specific evidence to supplement it or to give it mandatorily in any thyroid disease. To summarize, there is no specific thyroid diet for the patient, is what I try to tell them. And the other thing is, of course, people say that they want to reverse the thyroid, and we actually tell them thyroid is not to be reversed, it's a gland. Hypothyroidism is a disease. So I'm sure all of you must be coming across that.
Thank you, Dr. Unnikrishnan. Since we are dealing with very basics of the thyroid, the science of thyroid disease, I'll not go into the cancer part in detail, but I'll try to end, because we have the last 5 minutes, with a very common problem that we face in clinical practice, which is just a solitary thyroid nodule accidentally discovered by some routine investigations. And we do not have such high volume sonologists normally reporting. So I think we physicians should be equipped in writing certain criteria, that this is how I want the reports when you send me when I send you for an ultrasound of the thyroid. How exactly do you tackle when you see patients? Do you just write, go and get ultrasound done, or do you specify that I need to see certain aspects written in the report?
So this is for me or Uni?
Yes,
So
for
you
you.
can take it. Dr.
Yes,
Satinath, you can take it.
yes, it is for you.
The best way to evaluate a thyroid nodule is to train yourself in thyroid ultrasonography and do it yourself at your clinic. See, there are endocrinologists in the country, including me, who are trained by the American Endocrine Society. We are certified. Problem is to find the time to do the ultrasound yourself. So what I do in my private practice is that my office has an ultrasound room in the very next room, and I schedule the thyroid ultrasonography at a time when I am there. It coincides with my office timings. So I have the sonologist there, and I ask her, whenever you are asked to do imaging of either thyroid or parathyroid, please give me a call. So she just moves the probe around, and I see what I need to see, and then ask her, what's the thyroids you're talking of? If she says 3, I again ask her, why not 2? Just justify, and the job is done. It doesn't take more than 2 minutes.
Correct. Yeah.
So either you do it yourself, it's not feasible, you stand beside the sonologist and get a thyroid score out of her. In UK, they use a thigh scoring system, which is I find practically more useful, particularly from the GP point of view, where the thigh score tells the GP whether to keep the patient under follow up and under his umbrella, or he has to refer the patient to a thyroid specialist.
So can I
And
say, Dr. Mukhopadhyay and Dr. Unnikrishna, is it a message that we want to give for our physicians who want to do the screening, that when you ask for an ultrasound, ask for a T-RED score, and when you want to do an FNAC, ask for a Bethesda score? This is the basic thing.
Yes, I would agree with that.
absolutely 100%.
Okay. So I'm sorry for stopping you. You can continue, Dr. Mukhopadhyay.
No problem. And then again, in the evaluation of thyroid nodules, is the most important point is to ask the patient, when did you notice this nodule first, and is it increasing in size? The second thing is to find out if there is any suspicious lymph node on examination. So a lymph node increasing, a nodule increasing in size, no question about it, the patient needs a hemithyroidectomy. So even you need not wait for the FNA, take the thyroid, half of the thyroid out and do a histology. And this is curative in most situations. And then you may always go back to the patient depending on the histology report, differentiated thyroid carcinoma, so completion thyroidectomy, and then you do whatever is needed further, thyroxine suppression and radioiodine ablation, all those things. Yeah, right.
Thank you. Thank you very much, Professor Mukhopadhyay, and thank you very much, Dr. Unnikrishnan. I hope our audience have enjoyed this evening and got a lot of important information on thyroid disorders. Thank you very much and good night.
Thank you.
Thank
Thank you
you.
for having
Pleasure.
me.
Pleasure to
Bye.
be here. Thank you.
Bye.
Thank you.